confirmatory. For this particular diagram from Rosanna Peeling that was published in the WHO is still the one thing that several of you on today's call who have met me before have seen me use time and time again to remind people that when you have syphilis titers following the acquisition of infection, weeks later is when you develop these antibody responses, and there is a delay. However, what is known is that we can use one to track treatment, the VDRLs and RPRs, so still really useful. For all their deficits, they're very useful for this, even though there's a little delay after you treat, it's not going to pop down to nil immediately. And in fact, we give it time to do that. The other thing is just a reminder that the treponema antibody, once you have had syphilis once, is likely to stay positive for a lifetime. That second set of antibodies that's more specific to T. pallidum, lifetime positivity, okay? Those never drop or go away. And so this graphic shows where the antibody levels might be following and contingent upon what's the external appearance of the patient, the clinical stages of syphilis. It's overlaid on each other, months, weeks, months, years. One more reminder, those titers that plague us in interpretation all the time. Because the assay is not perfect, what CDC and experts have recommended that we do is we don't over-interpret a titer. When a titer rocks between one dilution, 1 to 4, 1 to 8, that's a one dilution, twofold change, okay? If it just rocks this much, we consider it not significant until we see the direction of the action. We repeat it, and we see whether or not it becomes a 4-fold, or it drops 2-fold, or where does it stay? But is a 1 to 4 materially different than a 1 to 8 in an asymptomatic patient who you've been tracking for a long time? Not necessarily, because these titers are so imperfect. And again, there might be lab to lab variation. So we don't make hay of them. We don't chalk up significant changes unless there's a 2 dilution or 4-fold decline or rise. And you'll see many times public health advisors will advise clinicians on the front line, hang on, this patient is asymptomatic and we have a little time, repeat that titer in a week. Let's see where it's going. Unfortunately, the other complexity as clinicians that we have is that there are so many things that can cause these titers to go positive, which have nothing to do with syphilis. So, for example, a whole bunch of viral infections, infectious mononucleosis, hepatitis, varicella, measles, sometimes those even cause positive antibody to cardiolipin, lecithin, and cholesterol, the RPRs and VDRLs. Sometimes non-treponemal tests are flagged as positive because you have a systemic disease like lymphoma, TB, or malaria diffusely, or endocarditis, or connective tissue disease. But at the end of the day, when you have a titer that's positive and a treponemal test that's positive, we go ahead and act on it because syphilis is one of the extremely treatable diseases. We don't over or under interpret the possibility that it could be a cross reaction with Lyme, the possibility that it could be mono. We just go ahead and treat because treatment is so simple with a single shot of bicillin usually. Yes, let us be aware of the fact that treponemal tests, other spirochetal illnesses like Lyme, leptospirosis, rat bite fever, relapsing fever, yaws, and Pinta are going to flag even what we think are more specific and unique to treponemes and T. pallidum, not the RPRs and VDRLs. Sometimes these can flag as positive, and it can be a false positive from the perspective of syphilis. But a couple of things, people in your region, Eugene Shapiro and others, have pointed out that the VDRL is non-reactive in Lyme. This is a subtlety that sometimes infectious disease clinicians will know. This list comes from a pediatric Bible of infectious diseases, the AAP Red Book, and is really useful still. It's the single best listing of false positive syphilis testing. But again, let me go back to the home point. Regardless of what your testing is, if the testing is positive, and there is no reason 100% to put a pin in any of these other diagnoses, these diagnoses become ones of exclusion, and you may choose to go ahead and simply treat for syphilis, as we all do. Evolution of the syphilis test. Fortunately, there has been some evolution. We have these traditional tests that are manual. We now have more automated test platforms. They do include things like large volume assays that are enzyme immunoassays, okay? But they also include more automated ways of, instead of pipetting by hand to get an RPR dilution, a serial dilution, some people are so lucky as to have a machine that will do it for them and at least titer out to 1 to 256 or so. And nowadays there are even rapid syphilis tests, but these tend to be more focused on treponemal antibody. And as Ava pointed out earlier, there are a number of individuals in our communities who are getting repeatedly infected with syphilis. So following a TPPA over time doesn't make sense, right? Because they're always going to be permanently positive once they originally acquired. It's their RPR VDRL titer that you really need a rapid handle on. Especially for these rapids, the other issue is they haven't become in wide circulation because there are a lot of concerns about sensitivity and specificity. And let's just be honest here, we often make the diagnosis of syphilis by serology. We generally do not have a direct test for the organism itself. So this brings to mind why we're actually potentially switching to the enzyme immunoassay as the first syphilis test, not the good old-fashioned RPR VDRL. Well, RPR VDRLs, unless you have that magic machine that can titer out, typically we're done looking for flocculation on a card. That is manual, that is slow. Look at the contrast to if you could screen 180 people per hour with no manual pipetting, no exposure. Boy, labs thought this was really yummy. And there is in fact a developed reverse algorithm for reverse sequence syphilis screening. CDC still remains agnostic. Look, at the end of the day, we basically just want to test people who are supposed to get screened or supposed to get diagnosed with syphilis with any syphilis test. But you basically have to pair it. You always have to have an RPR or VDRL, combine a TREP and a non-TREP test, one for the titers and one for the general confirmation. This reverse sequence algorithm, though, was worked out by, again, somebody in your own backyard, Justin Radoff, who I believe is still at UConn, okay? And he wrote this MMWR back 10 years ago. And he said, look, you can start with the enzyme immunoassay, which is nothing more and nothing less than an automated TPPA or treponemal assay, okay? 3% of them, unfortunately, will be positive, 57% of which, 50-50, you might get a negative RPR, a situation we never would have heard about before had we started with the positive RPR. So unconfuse yourself as a clinician by doing a third tiebreaker test. And the third tiebreaker test will always be something like a TPPA, a good old-fashioned treponemal antibody that's not automated in 180 tests later on a test platform. Each one has its trade-offs. We have come to understand during COVID, the trade-offs we take with more sensitive assays that can be done slower, or can we make assays so rapid and sensitive and specific? We're still in development with COVID. My goodness, we're still in development with syphilis as well. There are a lot of trade-offs to each way. Just understand each way has its perils and pitfalls and its advantages. So with reverse sequence, which we're seeing more and more, and the lab will discuss, your Connecticut State Lab will discuss the fact that it's shifting gears to this. And we did this a number of years ago in Massachusetts, just so we could accommodate larger screening volumes for all the false positives we might come up with. We just needed to really upscale syphilis screening. You're at that point now. The lab will be discussing it with you. All reactive EIA-CIAs on this automated platform need to be confirmed with an RPR. And if the RPR is negative, even then, a better treponemal test than the original EIA is recommended, and it typically is a TPPA. Please don't do the fluorescence test. A lot of labs are really inexperienced at this point. That's typically not recommended. Ina Park has the single best head-to-head comparison of all the treponemal assays, and it's indicative of the fact that all along we suspected that TPPA was the best platinum standard to compare it to. So do that one. That's for serum. This is not about CNS, okay? Let me just clarify. And all of these tests should be reported simultaneously to a provider, so the provider isn't stuck midway through the algorithm on hanging on how do I interpret a divergent result between the original EIA that could be positive and a negative RPR. You're going to get the TPPA at the same time. I don't want to forget herpes. Herpes diagnostics haven't really changed except for one thing I'm going to highlight from the 2021 guidelines. So I'll just remember with you all that the ways we make herpes diagnoses are a little different than syphilis. We either use viral culture, which has variable sensitivity depending on that stage of that lesion, right? The vesicular stage has more active viral replication that we can capture in growth in culture. Serologic testing, we can now use to differentiate between HSV1 and HSV2. I'll touch upon that in a moment. And lesion PCR is often where we go if you can order it, if you can send out for it, okay? You swab the lesion and the lesion itself can be PCR assayed for either HSV1 or HSV2. For serology, doing a blood test for herpes, unfortunately, does not tell us how long a person has been infected, how long they have had or will have symptoms, how likely they will be to shed asymptomatically, where they were infected. So if HSV1's portal of entry and recurrence site is on the mouth versus the genitals, the blood test is going to be positive no matter what, if it's a reasonably sensitive test, right? So it doesn't tell you if the genital lesion is specifically herpes 1 necessarily. It can't diagnose a lesion. It's just telling you, has that person ever had prior exposure and mounted an antibody defense to either HSV1 or HSV2? And then the worst piece of bad news about serologies with HSV, there are false positives and false negatives. Those serologies for HSV are just not great. So here's where we are in 2021 from Khalil Ghanem's update at a whole network-wide East Coast update. Some of you may have tuned into this, but now I'm going to put it in this context that Dr. Ghanem and Hopkins reviewed the subsection on herpes serologies, the recommended blood tests, if you're going to do a blood test, which is not universally recommended to screen everybody, but if you're stuck doing it, say, because you're managing a partner of somebody who has active lesions and you want to know the partner standard, then what you will send is typically something like a herpes select, okay? There are issues with specificity, so use an index value that's higher. If it's a lower index value, you should send a second, more specific test. And they are named. This is very unusual. In the STI treatment guidelines, they actually call them out by name. You know that government doesn't like to espouse particular companies, tools, or particular drug names, right? But here, the STI guidelines have actually called out that you're either going to try to send a Western blot to a research lab, the University of Washington Research Lab, or you're going to send specifically the BioKit rapid test, developed in Lexington, Mass. Who knew? So here we are. These are your options if an index value is lower on the first screen EIA. So you're starting to get a sense of the first screen EIA may be easier for a lab to do, but there is some level of confirmation that needs to be done, either for syphilis or for herpes. If you're in a setting where you're concerned and you're not sure that it's quite as specific as you need it to be to make the diagnosis. One more point and a reminder, please don't use IgM serologies. They are neither sensitive nor specific to diagnose a recent infection. One of the tricks about herpes that it plays on us is every time somebody gets a recurrent herpes infection, Unlike other IgM antibody defenses, which you typically mount only the first time you have had the infection, when you have a resurgence of HSV on a recurrence, you can reactivate your IgM production. So it doesn't tell you if it's a recent infection, which is what people purport or companies may try to say. They shouldn't. The FDA hasn't allowed them to say this. The IgM serologies are also problematic because there's a lot of overlap between IgM and IgG. Let's not go there. Please don't order IgM serologies if at all possible. All right. A few more take-home points before we take a little bit of a break and actually launch into some vexing cases together. Because there is more disease, we will see more complications. Right. If you used to see 100 cases a year in Connecticut of secondary syphilis, and now you're seeing 1,000, and I get done telling you that 3% of all secondary syphilis cases evolve, if you look closely enough, into neuroocular and otic syphilis. We just went from 3 to 30, if I did my math right? So you will see more complicated disease. That was what Ava was referring to. And in fact, this is a picture of Connecticut's reported syphilis cases and gonorrhea cases over time. There is a creep upwards. The nation is no different. We are going back to 80s levels, 90s levels of syphilis and gonorrhea. Why? The suspicion from the part of public health and more senior members like my mentor, Aldi Maria, who was the former state epi at DPH, was these decreases were due both to behavior change and deaths. Okay, what do I mean by behavior changes? Well, back in the 90s and 80s when we didn't have good treatment for HIV, people under the peril of potential acquisition of an STI, HIV, that could kill you, would change their behavior. They would use condoms more consistently. They would cut down on the numbers of partners. Here we are, 2021. Thank goodness we can relay to our patients that there isn't really going to be an STD that can kill you at this point. We can fix a lot of things. We may have to put you on meds permanently for now because we have no cure for HIV. But the point here is that the fear is gone. That's probably a great thing. It is a thing. Whether it's good or bad, we must accept it. And there's one more point. The way in which the drops occurred in the 90s was a way that public health would never go. Essentially, syphilis, which was a very rare STD even then, this is relatively rare when you're talking about only 1,800 cases on a base population that's not more than a few million in Connecticut. Okay, this is still a rare disease for all that we're really stressed about it and the numbers are going up. What I'm trying to say is HIV and syphilis co-infected individuals because they couldn't have their HIV solved. Some of them were dying. That is not a strategy. Culling the population to reduce the burden of disease is not a strategy that we espouse in public health, of course. That may have been one of the contributors to the declines back then. So what are our goals now? Knowing that both syphilis is totally treatable and curable and herpes is totally manageable by antivirals, the goals of early treatment are to prevent morbidity from complicated secondary, tertiary, and congenital syphilis, and antivirals can also save us from some of the more severe manifestations of HSV if we can control them. But I'm primarily here going to focus on how we will trim the complicated secondary, tertiary, and congenital syphilis manifestations. So here's what we're trying to avoid. And more case reports are coming out now. I bet you Connecticut Department of Public Health may have even heard of scattered case reports of somebody going to the OR because they have a thoracic aortic aneurysm. And you betcha, on pathology, when they see the treponemes in the intima of the wall that was resected, they figure out that person had syphilis in retrospect, probably acquired a decade or two prior, missed, never treated, never screened for. This is to be avoided. This is to be avoided too. Think about when you are in that secondary phase, and I mentioned that 3% of secondary cases, or during that spiral tetanic phase, 3% may cause evolution of eye and ear and central nervous system findings. What do you look for, or what are these manifestations? Well, ocular syphilis, as a reminder, can be a conjunctivitis, a scleritis, an episcleritis, or a uveitis, or a retinitis. Basically, almost any part of the eye can be involved, and the symptoms will be variable based on the eye involvement. For many of the surface ones, or for many of the surface findings for ocular syphilis, they're painful. So some people will report eye pain. But if you only have a uveitis, you can have a very subtle, just a bunch of floaters, non-painful, or a bluish tinge. For a retinitis, typically at that point, you're going to get visual acuity loss. And those are the ones, the posterior ones, that we're much more concerned will progress onto visual acuity loss that may be permanent, including blindness. Again, to be avoided at all costs. So how do we avoid it? Well, what you're going to see on the front lines is somebody who has a titer that's high and maybe in the spirocutemic phase and may even be symptomatic with secondary syphilis. And you will now never forget that we should use a screening tool to identify patients who need specialty care. This is a good tool from the Seattle King County Public Health Department. Symptoms of otosyphilis: have you had recent trouble hearing? Do you have ringing in your ears recently? Ocular syphilis: recent change in vision, flashing lights, move or float in your vision, blurring of your vision. Please ask your patients, because you know what? We've all discovered that our patients are really busy people. And sometimes, oddly, they don't think to report these things to us because they're not connecting that finding, the eye or ear finding, with the secondary syphilis that you're diagnosing. Are you having headaches? Have you recently been confused? Maybe better to ask a family member about that. Has your memory gotten worse? Do you have trouble concentrating? Do you feel like your personality has recently changed? If you're asking the index patient with secondary syphilis, or somebody who you think has early syphilis, maybe no visible manifestations, but you're screening them, ask for recency in these things. And you are going to identify some people who you will want to send to ENT or ophthalmology very quickly for a slit lamp exam or hearing tests. Why do we want to identify these individuals? We'll touch upon the fact that when you get CNS involvement or eye or ear involvement, the level of penicillin you need to give a patient to treat their syphilis needs to be much higher. So we're going to start to touch upon it here. In terms of guideline evolution between 2021 and 2015 guideline, there has been an evolution in who does and doesn't need an LP. So say you find the person with headaches or cranial nerve findings. One of the things is we would recommend LP, right? If a person didn't have a fourfold decline after waiting a full 12 months for early syphilis and a full 24 months following therapy. The guidelines have gotten clearer. It's not 6 to 12. It's now wait the full 12 if the person is relatively asymptomatic. You can wait. If yes, any neurosigns and symptoms, however, then you still need to do the LP. If the patient could have been reinfected, treat not the CNS, but with a repeat shot of bicillin. A fourfold increase in titers after therapy. In these situations, we also think about LP, particularly if there are neurosigns and symptoms, and if the patient could have been reinfected, we would treat with bicillin, not with IV pen. In terms of who we do it with CNS signs and symptoms, pretty much everyone who also has a titer elevation, or if you're diagnosed with tertiary syphilis, if you unfortunately have already reached cardiovascular or gummatous stages. And we also consider LP in those who are asymptomatic, and these are people who are going to need referral, of course, but whose serologic titers increase fourfold after stage appropriate therapy, like mentioned in this slide. There are no data to support routine LP in asymptomatic persons living with HIV, and there's no necessity for a follow-up LP 6 months after the diagnosis and treatment of neurosyphilis and HIV uninfected individuals who are AART, improving serologically, and their serum not central nervous system titers, are responding appropriately. We think they've responded. So some of these are the fancier things that are about when you LP, when you don't LP, and when you should consider LP, all of which are detailed in the guidelines in a stronger way, a clearer way than the 2015 guidelines. That's what I'm trying to point out here. One more refinement. Fortunately, for solely ocular or otic symptoms, solely, meaning you have secondary syphilis, okay, that's fine. But if you only have ear symptoms or eye symptoms that wind up being documented on like a slit lamp exam and the person has anterior uveitis, that person normally has a CSF exam that's normal. So the utility of LP has been downgraded, and we don't always LP everybody with pure hearing or pure eye symptoms in the context of secondary syphilis. The therapy, however, is the kind of level that we can get into the ocular, otic, or CNS environment. Last but not least, Ava told you about the story of the missed case. On so many levels, it was missed and evolved into congenital syphilis. Both syphilis and herpes have implications for the 2-for-1 deal, the as yet unborn fetus. So for syphilis during pregnancy, the 2021 syphilis update is there are many risk factors that you're all aware of. Many of these have not changed: drug use, unstable housing, homelessness, commercial sex trade, trade for sex or money or drugs or housing. All of these are risk factors. And there is some language in there that essentially says for pregnant women, please go ahead and treat with 2 doses, not 3, not 1. It's maybe preferable, experts still believe. Finally, the real big change is that they are being a little bit more permissive, actually. For clinical standpoint, this is not the definition of a surveillance case of congenital syphilis. From the clinical standpoint, you still have about 8 days to get that second dose of bicillin in. Or if you're treating a woman that deserves 3 doses because they have latent syphilis, then you have about 8 days, but greater than 9 days, and certainly slipping to 9 makes all of us nervous. We really prefer 7 every once a week around the same date at least. But they're allowing a little bit more. 2021 is changing the language specifically here, 9 days versus the very, very, very strict 7 that was previously written about. And yes, in Massachusetts, we finally picked up on what our Connecticut colleagues have been recommending all along. We do now do 1st and 3rd trimester screening in everyone because our signals in Massachusetts are very similar to yours. Everyone in New England is now seeing a few breakthrough cases of congenital syphilis. These are the red bars of the ones in Massachusetts, which scares all of us because we had years where many of us actually saw no cases. And this is definitely the signal, what Ava was talking about, of the creep back into heterosexual populations. For herpes, the newer messages: at the onset of labor, all women should be questioned thoroughly about the symptoms of genital herpes. I know this may not be relevant to any of you who aren't family practitioners or actually doing delivery, so I'll go through this pretty quickly. And they should be examined for herpetic lesions and managed accordingly. And the last message: fortunately, how we treat and manage syphilis and herpes hasn't changed much either. So here are the guidelines for syphilis. I'll just use this as an opportunity. Yes, primary, secondary, and early latent, 1 dose, unless you're pregnant, in which case we tend to recommend 2 doses, as I mentioned a moment ago. Late, latent, or non-primary, non-secondary, and not early. Benzathine, penicillin, once a week times 3 doses. The 2010, the 2015, and the 2021 guidelines have not changed, okay? The reason we use IV penicillin for neuroocular otic syphilis without a tap anymore, sorry, I forgot to correct this slide. I will do that before I disseminate the slides, okay? We don't necessarily tap, but we do use IV pen for 10 to 14 days and consider benzathine penicillin for that 3rd week as a chaser to match what happens with latent disease. When we do this, what you're achieving with 18 to 24 million units per day is way higher than what you're doing with 2.4 million units IM times one dose, right? So this is what gets you the treponemalcidal levels in the CNS that you can't achieve with bicillin. Last thing, in red, we are now seeing enough treponeme burden to have occasionally reports of Jerich-Herxheimer reaction, something that only really people who treated syphilis in the 80s and early 90s may remember. Because remember, our HIV-infected patients sometimes had higher treponeme burden. It's those people with a terrible high burden. Sometimes this is also in pregnancy in second trimester or third trimester. You have a higher burden of bacteria. As you go to kill the bacteria with the doses of penicillin you're providing, the person can become febrile, can become hypotensive, subtly so, we hope, and can not do so well. So if you have a suspicion that somebody has a high level of bacterial burden, some people, particularly with pregnant women in a take no chances kind of approach, have been hospitalizing some individuals, even if they look great, for that single shot, just for ops for 24 hours after the single shot for treatment. If you're worried that they have a high bacterial burden, it used to occur in older literature 30 to 70% of the time in these early syphilis phases. I'm not sure that's going to be the case. We're going to have to move forward and monitor for this potential complication. Follow-up of titers. All patients should be tested for HIV. Please don't forget to do that if you diagnose syphilis. And HIV PrEP is recommended for all those who are not already infected. Key point, if you acquire syphilis, you are in a network where you are at higher risk for acquisition of HIV. That is still true in 2021. Quantitative serologic tests should be repeated, and typically in HIV negative individuals, and again, we bifurcate here. HIV negative individuals, we do 6 to 12 months after primary and secondary, 6, 12, and 24 months after latent syphilis. Of course, the world is not perfect. Sometimes our patients are catch as catch can. Yes, there are many exceptions to this. In HIV co-infected individuals, quantitative non-TREP serologic tests, the rules are to repeat them more frequently. So you can get anxious about the results more frequently. Great. Looking for that 4-fold or 2 dilution change up or down, hoping that it goes down following treatment. So you do 3, 6, 9, 12, and 24, 6, 12, 18, and 24, depending on the stage originally diagnosed at. I cannot emphasize enough, any patient with syphilis diagnosed in 2021 is a candidate for recommendations for HIV PrEP. This is now licensed for adolescents greater than 35 kilos, and there is new guidance coming out of the AAP within the month. And other authorities, CDC has long since done this, USPHS has long since done this. How you do it, how you start it, really thinking about coincident infections in sexual networks. Until we address population health and population burden of HIV and syphilis, we are likely never to get a perfect handle on this. And finally, we're never going to get a perfect handle even on the individual index case if you don't manage their partners. In conjunction with public health, if the partner has been exposed within 90 days to early syphilis, treat that partner, even if seronegative, because remember, the seroconversion doesn't always occur. Yet transmission is so high from one infected syphilis patient to another when the contact is to an early syphilis case, primary, secondary syphilis acquired in the last year. Exposed greater than 90 days to primary, secondary, or early latent, treat. If serologic test results not available, follow-up is uncertain. Exposed to late latent, you have time. Evaluate clinically and serologically, treat if syphilis is suspected. None of this has changed since 2015, 2010. All of these guidelines are the same, but it's reasonable to do this as a reminder because until you treat the partners, the patient may come back reinfected. For herpes, lots of new counseling points, now divided into herpes 1, genital, and herpes 2, counseling. decreased risk of recurrences and shedding with HSV1 genital versus HSV2 genital. So how interesting that you don't always have to take all your herpes 1 patients with terrible genital ulcers at the outset and immediately give them a standard antiviral to take all the time to suppress. Usually for herpes 1, they don't tend to recur as often. Herpes 1 doesn't find its happy home in the genital environment quite as well as it does in the oropharyngeal environment to recur and recur and recur, like the way herpes 2 does. So not every patient who has an initial presentation deserves antiviral on a daily basis for a year, not with herpes 1. So review that component and review the overall counseling guidelines, which have now bifurcated between a herpes 1 and a herpes 2 diagnosis, which hopefully some of you can get through lesion PCR, or perhaps if you're absolutely desperate, 6, 9, few weeks later, wait for the serologic response and use the bifurcated 2 rounds of herpes serology. Maybe. That's hard. It's much better to diagnose on lesion PCR or culture. Then you have direct viral stuff. All right. In summary, we have rocked through diagnosis, treatment, management of syphilis and herpes. We have highlighted the differences between 2021 and 2015, and we have summarized resources. Aha, I didn't do that yet. So the treatment guidelines are your best friend. Really, I swear, it's not just a governmental authority that you always want to buck. It's really helpful. Now, I confess to fully being biased because there are about 75 to 100 of us that get in on the game of writing these guidelines now, okay? Unfortunately, we review the evidence and then we don't publish until 2021 because small things like pandemics happen. And so the MMWR publication machinery gets bollocksed. And here we are, 2021, the thing finally gets published. It's actually pretty up to date. Okay, but there are also a lot of other easy ways to access treatment guidance and other things. So are they just treatment guidelines? Are they just STI treatment guidelines? The biggest argument was to change STI, STD. What should we do? Well, STI is the way to go now in 2021. It could be an asymptomatic infection, not just a disease or a syndrome that somebody's diagnosed with. So we switched to STI. But it is such a misnomer to call these treatment guidelines. They are prevention, screening, counseling, management, and treatment guidelines. And hopefully available soon. There will be an app for it again. It's under development. It was just slower. They wanted to get the master documents out and the wall charts out and other things. So these are going to be available. Hopefully it will ping us when we need to download the new one. I've already erased my old one. And instead I go to the web for many of the updates. And here it is, finally, one more resource that will be linked to in the app eventually and is already called out on the Master CDC website. To get in touch with one of us who love to talk all day long and talk your ear off about sexual health and STDs, go ahead and consult us through www.stdccn.org. It's linked to your regional STD faculty. And between myself, Dr. Zunwang Wu, who you'll meet next week, who some of you have met before, either because you've used this consultation service or not, or you've seen us in other settings. This is the way to reach us within 1 to 5 days. You get to choose the timeline of the response. We're usually pretty fast. One of us is always on call for New England. Myself, Zun, Phil Shan in Rhode Island, Erica Hardy in Rhode Island, and also now Kevin Ard at the MGH Sexual Health Services Unit in Boston. All of us are the ones on call for the system. Friendly faces, not stock photos, okay? Friendly faces, you'll get a New England regional consultant when you write in with your Connecticut question. All right. I'm going to pause there and ask if we have clarification questions. I'm going to end the slideshow, get you all back on screen, see if I've left you all in the dust and you're all asleep at this point. So hard to tell on Zoom, but some of you are kind enough to show up again. Come back on and we'll take maybe 5 minutes worth of clarification questions and then we're going to take a break. Oh my. Be careful if you're driving. I do it all the time too. I'm listening in. I love it when I see some of you walking and thinking about STIs when you're hearing one of these talks. That I love. Get out to the park if it's good weather today. We're a little bit cloudy in Boston today. All right. Linda, can I pass to you to monitor the chat?
Absolutely, absolutely.
If there are questions through there, but there are few enough of us, okay? You can one by one, hopefully not land on top of each other. Just go ahead and ask me if there were any clarifying questions that you had for today's talk. We're going to be working through cases. So we're actually going to be working through a couple of cases of genital ulcer disease. So we'll have more time to talk back and forth more actively in the next hour.
I do want to just ask Rachel if your question was answered, the previous question that you had in the chat, the proper test order for screening for patients with no symptoms. Was your question answered, or would you like some clarification with Dr. Hsu?
Rachel, can you take yourself off mute if you're on mute?
Oh, she says,
oh,
please.
Yeah, I'm here. Yeah, if you could just, clarify, for a patient who comes in just for like routine STI screening, no symptoms, what is the best, what the best test is for her?
Okay. So for screening, remember, it's actually not universal. It may be universal in your STD clinic setting. That may be a different situation, okay? Maybe almost every patient who presents to an STD clinic is universally offered. But the clinical guidance from USPSTF and the CDC is still to focus syphilis screening on the special needs populations, i.e., men who have sex with men, male anatomy individuals who have sex with male anatomy individuals would be more precise, I think, in 2021 to say, okay? Or pregnant women, or anyone in that delineated high-risk population categories, IDU, homelessness, sex for money or drugs or a place to stay, any of those things that you might imagine are higher risk are indeed higher risk. Those are the individuals who are supposed to get syphilis screening, okay? That is not necessarily true in an STD clinic setting. There are some folks who believe, and this is absolutely true, by the time you present to an STD clinic setting, you had to have had a reason to present to an STD clinic setting. So there are many guidelines in certain states. It wouldn't surprise me if, Linda, certainly in our system here, we draw one tube of, it's not one tube of blood, but we, do a stick, needle stick, and we get syphilis, HIV, HCV as a package deal. Anybody coming to one of the Massachusetts state-funded sites, okay? And that wouldn't surprise me if that also happens in STD clinics in Connecticut, yes? Yep, getting a couple nods.
Yep.
Yeah, okay. So that's not perfectly in alignment with guidelines overall, but if you think about STD clinic settings as having patients who have higher risk, then you're going to go ahead and do it. Then to clarify, Rachel, which test is best? Really, I am still agnostic. Really, any test is better than no test. Just do a test, right? And interpret the heck out of it using all the tools that I just gave you. Those tests are not perfect. That's what we've definitely learned during COVID. Testing is not perfect. Entirely to be interpreted in the setting of how probable did that individual patient really carry the disease that you're testing for. It's pre-test probability that governs whether or not the test results in a false positive or a true positive, or a false negative or a true negative, okay? So whether you choose the reverse algorithm because the state is flipping to it anyway, don't get loyal to the traditional one. Whether you have no option and you only have traditional, well, just please, oh my gosh, Ava's case totally reinforced the fact that you have to follow up with a treponemal assay too. Otherwise, sometimes the state doesn't get flagged and people can get lost. So you always need both tests. The reverse algorithm forces it within a lab. Some other labs, if you get an RPR, yes, they even force a TPPA, but not most labs. So just be aware of what your lab can do, what you have the capability of doing. And Rachel, are you in county health department, or are you more related to a community health center or Planned Parenthood?
Yeah, I'm in an independent health center.
So you may still be using traditional at this point. Not sure. Check in with your OBGYN colleagues and other people who do a lot more syphilis screening in your center. Either one is fine. Now you know how to interpret it.
So we have another question, and the question is, I had Harish, I can never say that, reaction with a patient with 1 to 128. Should I now attempt to hospitalize anyone with high titer BDRL, and at what titer should I initiate this?
Impossible to know. And it was S-True 001.
I think that's
Where did you
Ellen
go? I saw you
Spizzero.
earlier.
If that's you, Ellen?
Yes, that is me.
Can't
Yeah,
use
I
the
did.
titer. You can't use the titer to govern this,
No.
but the titer sure as heck is going to flag you forever and ever now, right?
It kind of is.
But your patient, may I ask a question? Did
Mhm.
they require hospitalization later? Or was it that you got called the next day and the person had a terrible fever and wasn't feeling well? Did they get hospitalized?
They did not. He reported to me very much what you're talking about, even a rash. And he said he'd never felt so sick. And when he stood up, he would almost pass out.
Yeah.
So my question is, how much counseling should I do that this is a possibility? Every person that I give Bicillin to, I mean, I hand them a pamphlet, of course.
Mhm.
You know, is there one thing should I say if you feel
Yeah.
dizzy or if you have a fever, call immediately?
Yeah, I think, you know, the older literature, as I said this happened 30 to 70% of the time. I'm no longer sure this is actually true. I mean, how many shots of Bicillin have you guys given on the front lines and never had this happen, right?
A very
But
lot.
how much were we treating latent syphilis with not as high a treponeme burden? Now we're in 2021. We're seeing more and more secondary, higher treponeme burden. Okay, so we're going to go back to something between where we were, where we never really saw that much of this, versus where we were in the 80s and 90s, higher treponeme burden. Somewhere in there is the sweet spot. But does every patient deserve hospitalization? The answer is no, because in fact, you answered that. They get a fever, they can manage with Motrin or Tylenol. It feels miserable, but you've got to tell them it's okay, drink plenty of fluids, and use these antipyretics and sleep the day. But you might want to prepare them for that, especially if you see overt signs of secondary, because most people with overt signs of secondary have higher treponeme burden. Do you do it with everybody with a higher titer? Oh my gosh. We've had a couple patients now who've been identified with a 1 to 4,000 plus titer now. I would probably have definitively counseled those individuals about it. But was it the titer, the host, or was it truly treponeme burden? I'd love to think those titers are a perfect reflection of treponeme burden and how much bacteria is going to get killed, resulting in the Jerick-Herxheimer reaction. But they're not. They're not perfect. Crazily enough, some people will mount these crazy, crazy titers, and they don't have that much burden at the time they mount it. So it's a bit unpredictable. We're all learning as we go along. There's maybe one category of patients that I'd prefer not to learn on an outpatient basis. That would be pregnant women. Pregnant women, higher titer, Jerick-Herxheimer at times was associated with a very difficult reaction, fever, hypotension, and potential for miscarriage. Okay, you have to treat the syphilis. You don't have an option. But those individuals, if you're at all concerned, secondary syphilis, pregnant women, we've definitely at the state vantage point when we hear of these cases have been reminding clinicians about JH, and we've been reminding them, you know, 24 hours of ops, or somebody with HIV, not well controlled, syphilis, 24 hours of ops following observation, following a dose of Bicillin. Please, can we hospitalize them again? Just so that we can hold their hand a little bit more. That's where I'm slicing and dicing it. And this is the art of clinical medicine, not so much the science. We're going to get more science, unfortunately, as we get more experience.
Thank you, Kathy. We do have one question about when the state lab will be switching to the reverse algorithm, and we're going to be covering that, Una, next week. Our state lab representative who's going to be here on next Thursday, the 28th. So she'll be able to provide you with a little bit more definitive information about that. The next question we have is Giovanna has a question about how do we address the second dose of penicillin after JH reaction with the first dose?
All right. It's not going to happen. It shouldn't happen. Think about the pathophysiology behind JH reaction. It's when you first cut into it and you first start killing the bugs and you have an immune system reaction to the dying bacteria. Okay, so it really happens with the first. That's a great question. Sorry, I forgot to overtly address it. We got it last week from a pregnant woman that we sort of really forced a hospitalization from Friday into Saturday, who we were more worried about. So yeah, I don't really worry about it with the second dose. And certainly with patients with latent syphilis, where you're pretty sure it's old and hidden, but not high burden. That's one of the secrets to latent syphilis. It doesn't tend to be as high burden, doesn't tend to be as transmissible, if at all. Those patients getting the 3 doses, if you're pretty sure they acquired it more than a year ago and they aren't immune compromised, which includes pregnancy or HIV, if they are not immune compromised, then it's very hard to get these reactions, I think. But we will all learn more together. I should not lie. Guys, I trained from 95 to 98 as a pediatrician. I saw the tail end and the benefits of antiretroviral therapy because the kids weren't getting hospitalized anymore in the wards. The teens weren't getting hospitalized anymore, okay? But have I, even I, one of the region's experts, ever seen JH in person? No, I didn't train in the 80s. I'm hoping some of you are on, and some of you did. Maybe somebody can speak to that. Well, I think the one of you who mentioned that you had it happen on an outpatient basis, and thank goodness the guy called you. I'm so glad he called.
We actually did have a case, and I'm not sure if Wanda Richardson, one of our other DIS supervisors, is on. Last year, we did have a JH reaction. I don't think she's on the call today, but Lynn might remember that.
Yes. Great.
So
Ava, can you pipe up and say what you just added to the chat? That's really important. Are you still there?
Yeah, I'm still here. Yeah. Just my camera's off now. So we have seen in some of our investigations a few pregnant women. A recent one actually was purportedly allergic to penicillin, and she was not treated until the 3rd trimester. So she was hospitalized and observed when they were doing the desensitization to make sure that she wasn't going to have an adverse reaction. And as Linda mentioned, Wanda did have a case that was hospitalized and did have a reaction and stayed inpatient for, I think, 3 days. That person was in their 2nd trimester when they were being treated.
Thanks. Yeah, you're just going to see, we're seeing more and more syphilis. We are by definition going to see more JH reactions. Expect the unexpected, right? Be prepared and to live with your patients through these processes. That will be crucial. All right, I think we should take a break. Many of us need the bathroom. Good 10-minute break. Then we are promptly going to start. Linda, are you still there? At 9:55, and then we're going to go until 10:55. I had all this airtime with you, doing some cases. Okay?
Sounds great.
We gotta apply all of this influx of knowledge immediately together in the next hour.
Sounds great. Thanks, Kathy. Thank you. And everyone, please make sure you come back to us at 9:55, actually 9:56. We'll give you the full 10 minutes. 9:56. We'll see you in a few minutes. Thanks. We've got about another minute. Hi, everyone. We have about another minute. There are a couple of people that need to get in touch with Barbara Gray. Let's see. Nina, Jacob, Nina, Joanne, Robin. Your names are in the chat. Barbara, how do you want them to get in touch with you?
Hi, it's Janine. I think just for attendance purposes for CNE data collection, if those folks identified could just give their full name maybe in the chat directly to Barbara, that would be helpful to us. Thank you.
Okay, so hopefully everybody had a nice little break. Got another cup of Joe if they needed that. We'll wait a couple of minutes for Dr. Hsu. Hopefully she will be back on. Here she is. There she is.
Yep. All right, for this part, it will cheer me up tremendously if any of you are in a condition to do this and it's safe to do this and you have enough bandwidth to do this, lots of ifs, ands, and buts, to come on camera, okay? No, don't worry, I'm not gonna like ask you to talk or anything based on your names, but it would be great. And if I can hear from some of you who haven't piped up yet with your questions and concerns, it's important. We are in a learning environment. We are not to be judgmental about each other's lack of understanding or greater degrees of experience or lesser degrees, right? What does my 13-year-old telling me all the time about middle school? It's about the growth mindset. Here I am, 2021, 20 plus years into my career, and I'm learning more and more about syphilis every day. So let us be in this growth mindset together. Let us reveal what we are not sure of when we manage these patients on the front line. And there are a lot of gray areas. I think it's, sometimes easier when I wear my state hat and I'm not actually examining the patient. But gosh, when I'm in that exam room with a patient and I have to put a pin on, do I fire up the bicillin that day or do I not? Those choices are much harder to make. You put your neck out for the patient. Do I counsel them about JH? Do I not? I understand, right? Because I'm not only doing this as a teaching endeavor, and I'm not only at the state, but I'm also in adolescent clinic, seeing a lot more syphilis than I used to, a lot more PID this year than I used to. We'll be talking about that next week. Dr. Wong will be walking you through all of that. GC and chlamydia treatment guideline changes. Oh my gosh, you want to talk about earthquakes and treatment guideline changes? That's coming next week. Hold on to your hats. All right, so for those of you who can come on and nod to me, it will comfort me. All right, so shall we get started?
Sounds good.
Okay. Here, we'll just start with the take-home points. How's that? We can do that. All right, can you, oops, did I do this wrong? I think I did it wrong. I did it in the wrong order. I have to share screen first, then hit screen 2. Oops. Don't worry, I didn't erase my entire slide deck. All right, Linda, can you see my screen 2? Just nod, I see you. Thank you for staying on camera for just a minute. Okay, great. And screen 2 is still not in projection mode. Here we go, there you go. All right. How long is it too long to wait to see a doctor? And this is a real case from just this past year. It was earlier this year. So you'll see the time date stamps on this. Okay, so let me walk you through what happened. Has this started happening in your backyard? A 26-year-old male decides to self-test for STIs using online testing. And you, the STD clinician, are about to get left holding the bag with his results. Because guess what? The online testing system, he was given a package deal. He was just coming off his parents' insurance, real story, didn't want to fork over for his own, and just decided he really needed STI screening. So they gave him a package deal for STI HIV screening, but not a single clinician has seen or heard of him yet. March of 2021, the public health department was directly notified because we got laboratory information on this patient. His syphilis testing was positive. Unfortunately, we got the treponemal EIA and the RPR at the same time, 1 to 128. Nobody has told him about this diagnosis. We have to go back in time. And our field epidemiologist, that's what we call DIS in our state, spoke to the patient and garnered the following history. He had noticed a rash on his stomach and waistline that lasted 2 weeks in November. He also had a sore throat, swollen glands, and mucus patches on his tongue back in November. And he had spotty hair loss since then. November. And we're already in March by the time we find out about this. December 2020, right, in the height of the pandemic in the New England region, left eye flashes, I think that was actually second surge, right? Left eye flashes evolve into black spots, then diagonal, weird, blurry slash. Saw an ophthalmologist, not ophthalmologist, you know, they're seeing the eyes. Let us not fault our opto colleagues for not taking a complete sexual history every time they see one of these patients. The sexual history was not taken. The ophthalmologist was not finding evidence of a specific uveitis and wasn't thinking about really doing a slit lamp exam, probably looked at the retina. The retina was okay. Visual symptoms persisted. March 2021, diagonal slash moves over to the right eye. He does the self-testing because he has no primary care or health insurance. By the way, he did have options during this time. Our outpatient clinics were open through this time. He, unfortunately, by the time the field epi gets a hold of him, also tells us he has a terrible allergy to penicillin, hives, and his social history, which the epidemiologists are really good at getting. He is bisexual, 6 partners in the past 6 months, insertive and receptive anal and oral sex, last sex 1 month ago, uses Grindr to meet partners, no condom use, and by the way, he had a prior history of gonorrhea. You know, this is one thing we've repeatedly noticed in state databases. The faces behind the cases are fewer than the case number. A smaller fraction of individuals account for a larger fraction of reportable bacterial STIs they repeatedly acquire within the network or the population that they're part of. Something we have yet to capitalize on if we overscreen, for example, particular populations. The strategy has been applied to male anatomy patients who have sex with male anatomy patients. But is even Q3 month screening frequent enough? Some people are starting to model and question that very question, okay? But this person had a prior history. Red flag needs more frequent STI screening. This person has a sexual history of being bisexual. Gender of partners is not always hetero. So we can move forward and say that this individual certainly deserves screening more often. So just gonna throw it out to all of you. What's going on with this patient's vision? Of course, I've planted a seed today. How urgent is the concern? So you're sitting in March and the person is reporting to you that this has been going on since November. Are you gonna hospitalize him? When there is an ocular otic neurosyphilis symptom, what are we usually trained and told to do? Okay, we can start there. What's the usual dictum? And what are some possible next steps? All right, I need somebody to pipe up who's bold and willing to stick out their neck. Has anyone yet managed a case of ocular or otic syphilis or neurosyphilis? Are you all now wondering if you've missed a case and whether that shot of bicillin really did the trick? It sometimes does. It sometimes does in non-immunocompromised patients, even though you don't get quite the level that you want in these environments. And if you ever use doxycycline, excellent CNS penetrance. We might prefer higher levels of doxycycline for treatment, but if you had to use doxycycline, as we might have chosen, remember he has a terrible allergy to penicillin, you can actually get really good CNS ocular and otic penetration with doxy. Some of you know that from having treated Lyme on the front lines. All right, so anyone have some experience with ocular otic neurosyphilis? Linda, can I ask a favor? It's hard for me to see the chat and monitor both my screens. So has anybody piped up in the chat?
Not yet, not yet, but there has to be a brave soul out there.
Maybe they haven't seen it yet, or are not certain they've seen. So then I'm going to bounce the question to those of you at the state, because it actually was something that came into the state. There was no clinician seeing this patient yet. What would you have done? What have we heard about ocular otic neurosyphilis? How emergent is it? Ava or Dr. Sosa or Linda, how urgent is it that the field epi get right in and get that person into care? What do we usually do?
Hi, this is Ava. I guess I'll speak up because other people are shy. So the cases that we've investigated like this are typically, we learn about them after the person's made it to the emergency department, at which point they get hospitalized and the first thing that's done on them is a lumbar puncture.
Right.
Great.
That is exactly what we're taught. And remember, in the last few conferences we've been with CDC, Ava, have you heard people piping up, especially field epis and DIS, sharing their experiences about some people on the West Coast who developed their eye symptoms and within weeks were blind, irreversibly so. Like the DIS who went out, investigated the case, couldn't find the case, and it turned out the person had had a history of secondary syphilis and was in the middle of getting a seeing eye dog because they had gone blind and nobody had yet picked up on the fact that it really needed syphilis treatment. These are the cases, just bear with us at the state and at the sort of more specialized level that we hear about, we have nightmares about, we never want to miss. And yet, I want to point out that this is a real case that I just presented, which had an evolution from a November to March timeline. So how can we put a pin in who needs hospitalization? Who needs that rapid push those buttons, get those people into care now, yesterday, proverbially? In point of fact, with this guy, we did do that, okay? It didn't matter that he hadn't really evolved since November of last year. The tipping point for ocular syphilis is not particularly known for when somebody's gonna go blind versus not. You really have to get them to an ophthalmologist quickly to make a diagnosis of whether or not, which eye structure is truly involved. And we know in December, he did see an ophthalmologist who just didn't pick up on something really obvious in the retina, okay? But now it's March. So in this person, we had 2 reasons to hospitalize him and talk to an ID consultant and get an ophtho consult wicked fast. 2 reasons. One, he had a pen allergy, so it was going to be difficult to give him the correct drug under a monitored situation. And second, we really didn't want to take any chances. Semi-emergent, urgent, emergent, slice and dice, doesn't matter. By the time we pick it up, we're like, no, you need to be seen, okay? It's okay to push that point. Even if the evolution of symptoms has been relatively slow, we don't know when it will necessarily pick up. And we are all advised with ocular syphilis, as with any bacterial infection, outcomes are always better the earlier you treat and gain control, okay? That is almost always true. So let us apply those tenets, even if we don't have a perfect database specific to syphilis. How urgent is the concern? We're not sure. So we're going to try to save this person's vision as much as possible and get them hospitalized. And again, I had a compelling reason. He was allergic. What are some possible next steps? In this person's particular system with healthcare, such as it was, no primary care, living where he was, we got him in through a community hospital that had an ID specialist that was connected to the state in no other way other than by name. We knew that this physician was at this particular community hospital, which this patient preferred to be seen at, okay? We admitted him through the ER, he got treatment. He was treated with ceftriaxone.
Wow.
Actually, before I get to that, thank
There are
goodness.
some comments in the chat.
Oh,
just so you know.
what's happening?
Someone's asking, can you treat, is there any advantage to starting with Doxy PO? And someone asked earlier, could you have used IV Doxy in the hospital? So notice nobody's monitoring the chat, so. I
No,
thought
I'm monitoring. I just was waiting for Kathy.
Yeah.
And
Linda's
then there was
like, make it
another,
polite.
yeah, there was another question of whether or not this person had been tested for HIV.
Yes, getting to both. Okay. So regarding the question of could we have given Doxy as an outpatient? Yes, that was an option, except for one thing. You'll notice in the United States, in the treatment guidelines for CNS, ocular, and otic disease, they actually give you no alternatives other than penicillin, penicillin, and penicillin. And then in the small print, they mention a few small studies that have been done with ceftriaxone, which has excellent CNS, ocular, and otic penetration, but it's in this fine print. There's no in the box recommended regimen for somebody with a high V penicillin allergy, okay? No in the box recommendation in the US. You go to the UK guidelines because suddenly some of you are like, oh my goodness, this stuff has been treated in Britain for a long time too. Let's see what the British do or the United Kingdom clinicians do. And there is an option for 200 milligrams of Doxy BID, okay? But it's not a US guideline. It's not a US guideline. You can look at that. Why is it not a US guideline? Because the acceptable level of evidence for the UK guidelines is slightly different. And we're so desperate for alternative regimens, they are willing to say, look, there are anecdotal case series of people doing just fine with Doxy on a higher dose to treat these types of things, okay? But that's not well known in the US, and you guys are now in the knowledge loop about this. Sometimes looking across the pond, the Atlantic, can give you some extra guidance for some of these STIs when you're out of luck with the United States guidelines and they're not giving you enough information. You're also always going to consult your ID colleagues for this kind of thing, or you're going to consult one of us on STD-CCN. You know it. That's what we're here for. Okay, so this patient, and don't worry, I won't forget the HIV question later. Actually, it was on this slide. He was self-testing for STI and HIV. Maybe I wasn't clear enough. And he was known to be HIV negative in March when he did the self-testing. So we were lucky enough there that the panel that he was screened with the online testing was quite good, even if he hadn't been touched by a clinician. So here we are. He had a rash, but he was afebrile. His vital signs were stable. He had alopecia. He had diffuse lymphadenopathy. He was HIV negative, purportedly, at that point in time. His opto exam, thank goodness. They got him to see the ophthalmologist within 12 to 24 hours, visual acuity 20/20, left eye, anterior uveitis, right eye, despite the slashes he described, the ophthalmologist couldn't pick up anything. I'm still believing the patient though. Here's an example of the rash. Here's an example of a younger teenager with a recent alopecia, really subtle. Can you blame a hairdresser for missing this kind of thing? They're not going to be thinking syphilis. And if you were to biopsy and stain with a particular type of stain, you might actually see treponemes. So the controversy at the time that I originally presented the case earlier this summer when we didn't have the guidelines out is a lumbar puncture indicated. No, not anymore if it's only eye symptoms. We use the screening tool, okay? This person, though, at the time, it was before the new guidelines were released, they went ahead and tapped in conservatively. And like many of the patients that are described in the new guidelines, because the tap doesn't usually pick up anything, they are now counseling against doing this. And indeed, his VDRL was negative, his protein and glucose were relatively unremarkable, and as was his cell count. So that is an example of Khalil's teaching, Dr. Ghanem's teaching, and he was the one who rewrote this subsection of the guidelines. The TAP is not very high yield when you have isolated ocular symptoms. There were some additional tests that the ID clinician thought to send because we're doing triple site testing now, and the patient had not ordered all these online tests. The repeat RPR was also done. because it had been a few weeks. We were chasing him down, or at least a week. So at the time of treatment, it is always recommended at the day you give the treatment, unless it was like the day before that you had the other RPR from, which is seldom the case. The day he did the treatment, he repeated the RPR, it was still stable at 1 to 128. Definitely, this patient was a candidate for HIV PrEP. He got started on it by the ID clinician seeing him. The treatment for neurosyphilis is actually 3 to 4 million units. Again, I'm reinforcing procaine penicillin can be used too, but that's a shot every day. Plus you have to take Benamid, probenecid, to reduce the elimination of this daily shot, which is a different version than the benzathine that most of us give for just early syphilis and lasts a week. Okay, so most people, although this is considered an alternative in the US, most people use the top regimen, the aqueous crystalline penicillin 3 to 4 million units or continuous infusion. Hold on, this patient had the allergy. So here's the alternative, 2 grams IV daily times 14 days. That was March, got his hospitalization, got tucked on an outpatient regimen through a line, got his ceftriaxone daily. By May, I love how many of you have seen this too. When the signs and symptoms of secondary syphilis melt away, reversal of hair loss, lymphadenopathy gone, his visual changes, unfortunately, were largely the same with 2 diagonal streaks in his vision, but he said they weren't bothersome, which was comforting to all of us, and they certainly hadn't progressed. He was down to 1 to 32 already. No, nobody was waiting the mandatory 6 months before they remeasured his titer. They went ahead and remeasured his titer and he had already dropped. There was no indication to repeat his LP because it was normal at the start of therapy. This we already went through. And I'll just bring up one question. Had he been positive, let me throw this out to all of you. What have you done in the past with somebody who's HIV positive and syphilis positive? Is it necessary to treat them for longer or with higher doses? What have you done in clinical practice? This is not just neuro-ophtho-otic cases. Just ask anybody with HIV and syphilis co-infection. What have you done in your practice? Go ahead and stick your neck out. Somebody put something in the chat and somebody tell me about it.
Yep.
Hello?
Yep.
Oh, okay. It's been, well, I had one individual who had ocular and he was HIV positive. The same treatment was given. It wasn't any additional treatment and he was a newly diagnosed positive.
Mm-hmm. Mm-hmm. Yep. Has anybody been around the block with this issue and why is this even an issue? Like, has anybody on this call today been practicing at least for 20 years like me? Got a younger crew. It's good. It's good to have new people. Okay, so I'll just comment that the reason this keeps rearing its ugly head is back in the day, remember how I was mentioning that some of the most serious grave syphilis cases, many times the approach back then when people were very ill and had very poorly controlled CD4 counts and were sort of later in their course of HIV, not, for example, like this patient who was acute that you're describing. Many times people erred on the conservative side. We didn't have evidence that we shouldn't. So we would go for longer with higher doses, okay? That has now been taken off the table. We have enough data and evidence to say in 2021, for the amount of syphilis and HIV co-infection we've been monitoring over the years, we have never been able to demonstrate an outcome change with higher doses of penicillin. And the best cohorts of evidence come from the military, actually, because they have highly treated populations of HIV infected individuals with decent CD4 counts on antiretrovirals pretty consistently. But even when your HIV is not perfectly controlled, the question is taken off the table now. For bacterial infections, our approach is much the same. We treat them the same way. We don't need higher, longer doses. Bacterial infections, variation on herpes though. All right.
Kathy,
Yes.
we do have a question. Actually, there was a follow-up to the doxy question before we get too far in.
Sure.
Would it have been wrong to start doxy 200 milligrams POBID as we work towards searching for an ID specialist?
No, but the monitoring, I think the ID specialist is less important in this case because the eye symptom was the real trigger for the emergency. The ophthalmologist is actually more important. So getting them in quickly to get opto, we had a package deal. We were going in through the ER and going in through a hospital. This is where you pull no punches. You go in through a hospital that has all these specialists on call. You just don't pull your punches at this point. So you hope you don't have to slice or dice. And in Connecticut and Massachusetts, we're pretty lucky. What's considered a rural area that has less access to specialty care is still only a few hours away from a site that has an ophthalmologist on call, a site that has an ID doc on call.
And then we also have another comment. One of our participants said that we have treated patients the same if they have HPV or not.
Yes. Thank you for helping me reinforce that point and take it off the table. I just wasn't sure how many of you have been practicing for longer and are still worried that your HIV positive patients may need more. Think bacterial infections with HIV. Bacterial infections like syphilis are handled the same way as if you didn't have HIV. Your monitoring might be more close, right? You monitor the titers more closely. You worry more about Jerick Herxheimer. But other than that, your approach is still the same. Your treatment is the same. All right. So this is one example, neurosyphilis, treatment outcomes the same, regardless of HIV status. All right, and you do monitor more often. We've gone through all of this, and I have one final slide I want to show with you. So we were puzzling over this case. We were like, wow, how did he make it from all the way from like November with eye symptoms that just didn't progress? And we went back into not even very old literature, and it's one of my mentors, Donna Felsenstein, who's definitely still here, okay? And Joe Tucker was one of her fellows, a whole group of them at MGH and Mass Eye and Ear. If you think about it, it's a tertiary quaternary care institution, which is going to get a lot of referrals. You need volume to be able to make statements about ocular syphilis. And the paper was ostensibly about HIV-infected patients, a systematic analysis of the literature. They also talked about individuals who were not co-infected. And here were the key findings they pulled out of their chart reviews, their exhaustive chart reviews. During the treatment era for HIV, the diagnosis of ocular syphilis unfortunately often led to a diagnosis of HIV, right? If you have syphilis, you're going to co-test for HIV. And unfortunately, a lot of people are picked up at that time in acute or semi-acute or recently acquired HIV. There was one more hint from all the chart reviews they did. Posterior uveitis with central choroidal retinal lesions and optic neuritis. Posterior retinal optic neuritis, the back of the eye, have worse outcomes. Anterior, and remember, this guy wound up with, on a slit lamp exam, an anterior uveitis, and other syndromes do better. Risk for posterior uveitis is actually correlated with a lower CD4 count because, again, they were really looking at HIV-infected patients. And appropriate IV treatment is associated with excellent outcomes, that nice high dose or that nice high dose of ceftriaxone that penetrates the ocular, otic, and CNS environments. Nice paper giving us some of the reasons why I worry so much more. You get them into opto, it's a posterior finding. I hope that ophthalmologist is demanding the rights to hospitalize a patient and get them on IV therapy with their ID colleagues. And you often want to run these cases through a larger center with an ER. Take no prisoners. Okay, take home points, screen. Sexual history taking is relevant for our opto colleagues, but think about the numbers of uveitis cases they see that never have anything to do with syphilis, and you'll start to understand why it's not routine. Treat neurosyphilis patients in patients with HIV with the same regimens. Few alternatives exist, but ceftriaxone and doxy, I've given you a hint that ceftriaxone is mentioned in the US guidelines and doxy 200 POBID is mentioned in the UK guidelines. Outcomes depend on the level of immunocompromise. Initial exam findings, posterior findings correlate with poorer outcomes, and speed of treatment initiation, as with any bacterial disease. Good treatment, good visual prognosis. Don't despair. All right. That was just the first case. Take a deep breath. Be ready for another one.
Kathy, hi, it's Linda. The screening tool that you showed us for the neurosyphilis, is that something that is available somewhere? It looks as though that was from Seattle. Yeah, okay.
We liberally borrow. Janine, were you actually able to find it on the Seattle PTC website, or is it just being duplicated on my slides?
I'm sorry, clarify again what you're looking for.
The Seattle King County STD clinic has a screening tool that you've seen me show multiple times on my slides. You guys are going to get my slides, so you could always reduplicate that.
Yeah.
The eye, the ear, the headache thing. Is that somewhere on the Seattle PTC's website too?
Let me research that right now. I'm not sure, but I will do that now and put it in the chat.
And there's no problem. This is not like copyrighted or anything. They
Yeah.
just solidified what was more nebulous in the guidelines about what you ask about. And they really put a pin in, you know, what do you ask when you're asking for vision change? It's not just vision change. It's like spots or dots. Some people, it wasn't on the Seattle PTC one, but some of our colleagues on the West Coast have said something about a bluish tinge to the vision. And you know, this guy described a slash, a really weird slash. Look, you're looking for any changes from baseline, basically.
Great.
So do you have to use this tool? Linda, I don't want people to get too wedded to specific language or anything, but it is one good example. Riff off of it so you don't totally reinvent the wheel.
Absolutely. Yeah. Janine can't find it. I will definitely replicate it and share, and people can use as they like.
I'm definitely going to give you a PDF copy of all my slides. That's going to get circulated. So some people have been known to take one of those pictures of the PDF and post that one in clinic, if that's helpful. But you know what? You do it a couple of times with patients in secondary syphilis, and then you're like, it's drilled into your head. Does it have to be perfectly that way? No. Okay. I think you got the key point. You got to ask, because they may not mention it otherwise.
Great.
All right. Other things in the chat about this case.
That's all we have in the chat so far.
Okie dokie. All right. Ready for the next one? Should be pretty brief. We're just going to review a couple other things. Let me see if I can pull it up quick and fast. All right. Hang on 1 second. Bear with me here. All right, sharing my second screen again with the massive slide decks that I have. You guys probably don't even want to know how much I actually am doing on this teaching. All right, so can you see my screen too with lots of slides?
Yes.
And now case 2. Yes?
Yes.
Okay, great. 24-year-old, again, a bisexual male who has sex with males and women. I'm sorry, sometimes those of us who are older default to older terminology. It's better to use anatomical terms, right? Individual with male anatomy who has sex with individuals with male anatomy and female anatomy. But sometimes we default to these terms because both from our epidemiologic leanings and the way CDC tracks individuals and risk factors, these are common terms we use. So we say MSMW, comes for evaluation of penile lesions. 3 weeks ago, new sex partner, no condom use. If you think about it, just look at these lesions for a second and pause, right? It's not perfect. You can't see them perfectly, but there's a slightly liquid quality. Can I convince you there might be vesicles? And some of them are a little broken here. And even if he had used condoms, there's no such thing as a full body condom, top to toe. And it's actually at the top of where a condom might be looser or not covered, right? So since herpes is one of the STIs that isn't just transmitted by body fluid, it's actually mostly transmitted by touch and friction, the act of sex. You could see how this could arise even if somebody had used condoms. Condoms are not perfectly protective against things like herpes or HPV. Good thing we have a vaccine for HPV. All right, so 3 weeks ago, new sex partner, no condom use, he says. 10 days ago, malaise, body aches, LBP. I don't even remember what the LBP was. We'll have to dismiss that for a moment. And he did have a low-grade temperature. Now, pimples on his penile shaft and pubic region. Oh, over here too. Headache and body aches are better. So this has been evolving. He's still got this. He's last tested for HIV 3 months ago, has been intermittently on PrEP for the past 2 years, no use in the past 3 months. Okay, we've set the stage. Tell me what else you want to know. And tell me what tests you would order, having heard my diatribes on herpes serologies. And what's in your differential diagnosis for this gentleman today? Okay, toss out some ideas. Get active. Could be in the chat or verbally.
Culture.
Yes, of what kind?
Ellen, you can open your, unmute yourself if you'd like.
Might not be able to. Could have background noise.
Put it in the chat if you
I
can.
would-
There you go.
Here we go. I would culture the lesion, the vesicles
For,
for herpes.
okay, great. Some people do bacterial culture. I wouldn't. It's vesicular. Some of them are scabbing. What do you think your yield will be 2-3 weeks into the diagnosis?
2 or 3 weeks into the, are they scabbed over?
A couple of them are, a couple of them aren't.
From what you said, about 70% that it's going to
Mhm.
come up positive.
And you know what you do? Practically speaking, you ask the patient, where's the newest ones? Are they the ones on the belly or the ones on the penis? You'll probably say it's the ones on the belly. And then what you're going to do is you're going to unroof the one that's the most recent one. He'll help tell you. The patient will help tell you. Okay.
So
That's the
take
freshest
the
one.
scab
That's
off.
the one that might have the most likelihood of shedding live HSV still. Go ahead.
When you have an intact vesicle,
Mhm.
should you find a way to get that to leak some fluid? Is that going to be just as valuable?
So what many of us do in practice, sorry, I snuck another bite of breakfast. What many of us do in practice, we'll explain this adult patient, they can handle it. Some of my teenagers wince. If you have a tiny needle with a sharp edge or a scalpel, you can unroof the vesicle. Remember, that was the best practice. Meaning you cut or you nick the top of a vesicle. It's very shallow skin, okay? So the top of the vesicle, if you nick it, no, none of us use local anesthesia for this, by the way. You quickly nick it, it actually is not painful. That's not the painful part. That comes next. Unfortunately, you have to take that Q-tip that's with your viral culture transport media, which should be a swab that is either made out of Dacron or rayon, right? Because viruses are finicky. They don't grow well with cotton or wood inhibitors. So it comes as a package deal. It's called viral chlamydial transport media if you look really closely at the small print. But it's essentially transport media. It usually comes as a 15 cc conical tube with a few cc's of pink media with some beads at the bottom that are inhibitors of bacterial growth because you're looking for virus or you're looking for atypical bacteria like chlamydia that requires cell culture. That is often the way labs prefer to receive viral culture, or even the PCR of the lesion now is transported to the lab in this, what's called viral chlamydial transport media. And not all of you are going to have access to this. This is where the world is not created equally. For example, I'm going to guess that the state lab does not have the capability, nor it's very expensive to maintain cell culture for viral culture, okay? But some of you working in community health centers that have relationships with Quest, Mayo, LabCorp, you can get this viral chlamydial transport media. You can unroof the vesicle, nick it with a very sharp scalpel or the tip of a needle, okay? And then dampen the swab with the liquid inside. And the base of these is sometimes a little bit painful, okay? Not the surface, the tense surface, but the base. Now, nobody reads the textbook, so you're probably going to come up with the next 10 patients that do this. You're going to be like, Dr. Hsu just totally lied to me. No, patients have variation, okay? So do the best you can. Patient doesn't tolerate any of this. Look, getting the swab in this area near the wettest vesicles or the most recent vesicles, do you absolutely have to unroof them for the perfect virus culture or PCR? No, honestly, you can look for shedding. Just rub it near the lesions. I know. Dr. Felsenstein would probably be regretting she ever taught me as a mentee. I'm letting you guys have an out here. But I hate making, I'm a pediatrician at heart, right? I hate making patients have pain, okay? So just be a little careful and just explain to them this is really the best way to make the herpes diagnosis, okay? Viral culture or viral PCR from that lesion. Anything coming up in the chat or people who want to chime in?
Yes, I just want to confirm that we do have the viral culture media at the state, so that is available.
Yay. But do you stock it at every clinic site or does it get kind of shipped over when they need it?
Ellen, I think you commented on that. If you want to chime in on that.
I just request half dozen or so and it gets stocked. It's not a per request. So it's right around.
And
check the expiration dates every now and again as you're stocking.
Absolutely. But I just sort of, depending on, the number of cases you think you see, the state has been wonderful to just, give us like a half a dozen at a time. And when I'm down to one or two, I request more. And I don't think it's ever really expired,
Right.
But that's kind of exclusively. The only other one that we have at the state had been the blood for, I think, and Linda it was the both type 1 or type 2, which would almost always come up positive because most people are positive for at least type 1 by the time they're 40. So I don't tend to do that because it doesn't give me the information I want.
Wait, sorry, I think I misheard that. You do or don't want the HSV 1 or 2?
Well, the culture will type it for me. I won't do a serum because I think our serum at the state, at least that option, Quest is different, but the serum at the state simply tests for a positive for either type 1 or type 2, which it doesn't differentiate. And then, 90% of people over the age of 40 are going to be positive. It's just so likely that type 1 will have ticked it off. And you have a lot of people panicking who've never had lesions either in their mouth or on their genitals who now think they're positive for herpes. It causes more panic. It doesn't answer questions.
Whereas viral culture and viral PCR will give you the answer that you're hoping for if you have the lesions to diagnose it off of. Yes.
Yes,
great.
That's exactly. I just explain it in terms of the limitation. If there's a lesion present, I will culture it, and if it's positive and it's on your genitals, you have genital herpes. Or I'll be able to tell you type 1 or type 2. But the serum test, I'm not even offering because
we'll review that
not
in
a whole
just
lot.
a second again.
In the chat,
only the
Kathy, we do have one more comment in the chat. Planned Parenthood, Sally says, we always do a syphilis test if there are any lesions.
Yes. Okay, so even for multiple ulcers that are painful, you go ahead in that setting, knowing that the two leading diagnoses are in the United States. Let me reframe for a second, Sally, that the two leading diagnoses are herpes, probably herpes, but you don't want to miss syphilis. So you go ahead and send syphilis serologic testing at that point. Great, that's fine. Let me just caution you or remind you, a negative syphilis test at the primary stage or the beginning stage, right? It's not always positive yet, because remember, the person has to have time to mount the serologic defense. You may want to call that patient back for another screen in a month to 2 months. If the herpes test comes back negative and you're still puzzling and you're like, maybe it was syphilis. Yeah, call them back. Call them back for the syphilis serology. Great idea though, don't forget. Okay, I'm going to give you a little additional history and physical. Neck was supple. We've got some lymph nodes, no additional lesions, no disseminated rash. Remainder of exam is normal. Does the adenopathy give you a hint one way or another? Is that typical of your herpes patients? Those of you who have seen this?
Yes and no.
Yes, very much so. Painful.
Yes.
Many of us actually have oral herpes. And you'll remember that if you have an oral herpes outbreak, you can get a local adenopathy reaction there too. And let me go back to something else this patient reminded us of. He didn't come in for this, but remember, he had malaise and body aches. And there are some really odd, cool, now I've just revealed the fact that I'm an ID doc, right? And I'm half in love with the bugs that I study, that I tried to kill, right? But what I'm trying to say here is, you know, some people who are in acute herpes also describe a terrible hesitation with urinary streams, okay? And that has to do with the sacral involvement of the sacral nerves. And sometimes they also have this issue with not burning with urination. That happens too. You get a urethritis with herpes. Maybe not this person. This person has it on the penile shaft, okay? But like the female picture that I showed earlier, burning with urination or urinary hesitancy. It's hard to get the stream out. That may have to do with the sphincter control and the sacral nerve being involved. Very interesting, okay? So if you ask closely, you query your patients with active herpes lesions, you might pick up on some odd urinary manifestations they may not think to tell you about. It's not going to change your treatment though.
Kathy, we do have one additional comment from Ellen, that they also see lymphadenopathy in syphilis.
Yep. So that's not going to help you one way or another. Does it tell you that the person has syphilis or herpes? No. Great. Thank you for overtly stating that. Okay. Thankfully, they did the same thing that you good people at Planned Parenthood do too. They did a syphilis IgG screen. That's nothing more, nothing less than the enzyme immunoassay that we talked about. That's the new generation. You can do 180 tests at a time. They did 3-site screening, negative. Herpes 1 PCR positive from an unroofed lesion, just like I described. 4th generation HIV antigen antibody was negative. HIV RNA, they were that worried because he had that prior history of a flu-like illness and fever, right? So he really didn't want to miss acute HIV. So they went ahead and tested for that. But that flu-like illness, that is in fact can be part of herpes initial presentation. Usually it's the first time, not every time you get a recurrence. You usually have better control by that. Is this primary HSV1? How can you tell? Don't use that IgM. I'm just reminding you. Would PrEP have prevented this infection? No. There's no HSV PrEP. There's HIV PrEP, but Truvada and emtricitabine, tenofovir and emtricitabine wouldn't have done a darn thing, per se. It does do things against, remember, HIV PrEP patients, we have to rule out hepatitis B. Remember that? At baseline, because it does have an influence on Hep B, but not this virus, HSV. Is this person's risk of HIV acquisition increased? Yes, yes, yes. Any genital ulcer disease increases. And to go along with what one of you mentioned, why these titers are so unhelpful, the bloodstream titers. By the time you get to your 5th decade of life, okay, upwards of 70, 80, 90% of the American population has antibodies, if properly measured, to herpes 1. For herpes 2, by the time you get to your 3rd decade, 4th decade, 25, 30% of the American population has positivity. So I'm going to skip over this. This is not my point today, and instead mention that we picked up on one other thing, right? Sorry, hopping back and forth. This person had genital HSV1. How interesting. So those of you who have been practicing for a decade or more, a couple of you, can I get you to comment on your impressions of what you've been seeing on the front lines with genital HSV? Have you been seeing more HSV1 genital or HSV2 genital? Think about the last few patients you've seen in the last 5 years, 10 years.
Ellen has a comment, more HSV1.
Yes, yes. 2 populations that get closely monitored, heterosexual women and men who have sex with men. Lots of oral sex behaviors reported, okay? And we think this is the seed of why. And also that they didn't acquire it when they were younger. And there may be partial protection. If you have it in the oropharynx, do you usually get it in the genitalia on the same person? Not usually. You develop antibodies and there's some partial protection, people believe, okay? This is still hypotheses. We're still learning a lot about herpes. No matter how dreadfully common it seems to be, we're still learning more and more about these viral STIs. So instead, what I will tell you is the data show when you do series of patients with genital herpes that have strong histories of oral sex exposure, majority of below the belt, i.e. genital herpes, is now herpes type 1. This is not a surprise. This patient's finding of HSV1 should not have been a surprise. It was actually the majority of the time now, okay? So does that change your management? Well, your counseling messages are different. That's what I mentioned to you earlier. Counseling messages are a little bit different, okay? Because herpes 1 below the belt doesn't tend to recur as often. So we don't usually try to put them immediately on suppression. Okay, so don't leap to suppression with these patients, even if they have a terribly bad original outbreak, okay? Don't leap to suppression yet. Say to them, you know what, we know it's herpes 1, let's give it a little bit more time. You may be in the category of the vast majority of patients who do not even recur even after the original outbreak was terrible. And it used to be true that if the original outbreak was bad and it was herpes 2, you were pretty sure, although I'm not sure I so much as told the patient, well, you're doomed, you're gonna have recurrent herpes genital 2. I don't say that, but if the how bad the original outbreak or the first pickup of the outbreak is somewhat presaging, somewhat prescient of whether or not they recur when it's herpes 2. Not so much with herpes 1, okay? So give it some time, work with your patient. All of us have had this experience of the patient who is in such pain, can't pee, and they're really not hearing you much at that moment that you're making the unroofing and the diagnosis. Bring them back. Bring them back for additional counseling. There are so many counseling messages that are wise within the STI treatment guidelines now, this year just released. Please review them with your patient, but when they're listening, able to listen, not in pain. You finish treating the outbreak. Bring them back. Much better tactic, as we've all learned. It's so hard. The patients have overt manifestations of a very visible disfiguring STI. And many of them, it's just really hard. You know, that first diagnosis, this has been some of the most difficult diagnoses I've ever had to give to my patients.
Kathy, we
We've
do
all
have a
had that
couple of
experience.
comments. The one comment was this, yes, more HSV, one on the genitals, and another just concurring that these recur less often, and the first episode is much worse, but fewer recurrences.
We can live with it with our patients, together with them. Yes. Okay, so some take-home points. Herpes 1 can cause genital herpes. In fact, it's the majority of genital herpes now in heterosexual women and men who have sex with men. Less severe outbreaks typically, but no one reads the textbook. So there's a wide spectrum of initial presentations. And there are some people who do have recurrent herpes 1. So you have to watch and monitor. You don't guarantee the patient the outcome at the outset. And perform the swab from the lesion to make that diagnosis. We've talked about all the dizzy details related to that. Don't do serologic testing with IgM. IgG is only helpful in partner management cases and in some, this is detailed also in the herpes subsection of the treatment guidelines. Like, when do you want to do serology? When is it helpful? It's not so terrible. If it was so terrible, they wouldn't be telling you to get the BioKit as the second test. You know, people are going to be doing some amount of herpes serology. When is it useful? Parse that out for specific patient situations, primarily partner management or pregnant patients potentially. IgM or IgG should not be used to make the diagnosis alone. Yes, those are the take-home points. All right. We are at 1 minute away from 10:55, which is when we're ending. And I had a suspicion that was going to happen. So I wanted to do a sort of really more complex ocular syphilis case that took a long time to get into care. And this case of straight up vesicular lesions below the belt, herpes 1. Nice contrast. I'm going to stop there, tell you all that I'm going to buck these slides and combine them into one of a 2-case slide deck, okay? And you'll get these too, all right? And I'll just end with, no, you know, I thought about incorporating a case with those titers that go up, that go down, that are measured every 3 months or every 1 month. We will have to deal with those cases one-on-one. You can ask the public health department for questions and answers. You can have ID colleagues weigh in. And, you know, at the end of the day, let's just all get wise to the fact that serologic titers with syphilis, they're imperfect. We got to live with them until we have better testing. Maybe someday we'll have a vaccine, okay? And for now, it will always be difficult to wrestle with titers in somebody who's had a previous infection, right? Previous infection means that you have to look at all their background history. Where were they when they started? What stage were they when they started? That's where the public health department becomes like gold. We maintain these records. We call to our colleagues across state lines and even across borders sometimes to find out ancient histories of syphilis titer and treatment to help clinicians on the front lines make the best decisions for just the right amount of penicillin. Not too much, not too little. And I'll end it there.
Thank you so much, Kathy. That was incredible. Always so pleased to hear you speak. You're so enthusiastic and it's catchy. And so I think it's been a great. It's been great. I wish we were in person, but you know, it is what it is. But I think we had more people today because we were virtual. So
next year?
I think
maybe next year.
Maybe next year. Maybe we'll be fortunate. So I do have a couple of ending housekeeping things that I want to share with you. Let's see here. I'm going to share my screen just really quick so I can run through this really quickly with you. So all of you received an evaluation when you received the link for the Zoom meeting. So you all received an evaluation. Please complete that evaluation and email it to Janine Dyer at mass.gov. You see her email address right there. That is so helpful for us to know how we did. Your continuing education certificate will be mailed once Janine receives your completed evaluation, and you will get another brief evaluation after today's session as well. So I just want to personally thank everyone for taking the time out and sharing your morning with us. We've got another jam-packed session for next Thursday. We'll be covering chlamydia and gonorrhea, and we'll have a update from our state lab, as well as a panel discussion on EPT, which I know that's something that many of you are interested in. So we really, really hope that you're able to join us next week. If you haven't already signed up and registered for next week, please do so. Registration is still open. If you have any questions about how to get back to the registration, let me know. It's in one of the emails that I sent you, the original emails about registration. But if you do have any problems, just please be sure to reach out to me, email me, give me a call, because we really want everyone to have the second part of this fantastic series of trainings and education that is so vital for all of us to stay up to date. Again, I want to thank Ava for her incredible presentation this morning to get us started, and also to Dr. Hsu for giving us a great overview and also some case histories to consider as we move forward. So we do have another 3 minutes actually. If anybody has any burning questions they might want asked, there is something in the chat. Please email the evaluation again. Yes, Tina, we will. That would be sent out. Kathy, did you want to say something? I'm sorry.
Yeah, I think she wanted to know the email. Can you put up your final slide while you're still chatting with everybody, and I'll monitor the chat too?
Absolutely, absolutely.
That was really helpful.
Thank you.
The evaluations do help us a lot, guys. And it looks like we are holding the CE certificates hostage until we get them. And they ain't half bad. How long is the evaluation, Janine or Linda?
Janine, I think
It's just a brief evaluation for our continuing education purposes. Likert scale, check off boxes, and then an opportunity at the bottom of the page to provide your open-ended comments and observations about today's session.
You know, it doesn't matter how many years I've been doing this. After every one of my talks, I actually still skim all of the open-ended comments. Those are really helpful. Even if it's just positive feedback, it's all good. I take it into account as I grow and develop as a speaker as well. Thank you all for listening. You were incredible today.
I had a quick question from sort of a rookie provider who's kind of new to a lot of stuff. So I just wanted to ask, so it seemed like pretty much any case of neurosyphilis is going to be, and this could be a cringeworthy question, any case of neurosyphilis is going to be pretty much like they're going to need treatment almost right away, immediately. Is that true? Are there some cases of neurosyphilis? I mean, otic and ocular has pretty extreme ramifications and pretty rapid progression, it seemed. Is there any other ones that could be handled? I'm thinking that most seem to be like refer to ED, get them into the ED for admission into the hospital is the best pathway, not say like neurology outpatient for trying to get them to figure out lumbar puncture details. Is that right?
I kind of tend to agree, but remember, healthcare systems in every location are different. So I've seen some miracles on the outpatient basis now in Massachusetts with certain healthcare systems, which never saw a neurosyphilis patient inpatient, but the ID doc saw them, got them on IV therapy very quickly as an outpatient, and never had to hospitalize them, and wasn't monitoring outcomes, on a daily basis or something. Okay, so I have been surprised. And what I often do when I'm working in partnership is you're going to get to know your region, right? So Jason, you're going to basically get to know your best friend who's the ID doc in your region. And you're going to say, hey, I heard this talk and I heard there's going to be more neurosyphilis that I'm going to be managing in the coming years. What do you think? Like, if it's not a terrible headache, can I call you up and get them into your clinic like the next day? And do you have the capacity for outpatient IV therapy? Because a lot of ID docs do that now, right? We've got a lot of long-term patients who need long-term antibiotics for other reasons, not STIs. So there are systems that can do that. I wouldn't assume, but it has to do with local systems and ability. Public health department actually often knows too. So working with the epidemiologists, the DIS, to ask, hey, do you think we should? But listen, you want to save somebody's head, eyes, or ears, and you're just worried, flat out worried, be the rookie and say, you know what? I really think you need to go to the ER. Let me help facilitate, and let me just get you in quickly. Okay, that's fine too. I don't care that other people will judge you. We will not. We just want to do the right thing by the patient, whatever it is. And these are, there's no one right answer to this.
Thank you.
Thank you for the question. Oh, Linda, I think you're on mute.
Sorry about that. So we just had some folks thanking us for the presentation. Can't wait till next week. I think there was a question about the whether or not the evaluation was going to be mailed to us or to you. And Janine said that the email with today's link and agenda contained the evaluation form. It was attached. But if you have a problem, Ellen, I can email it to you again so you can have that. And also, I'm going to put the general phone number for EPH if any of you have any questions. Relative, as Kathy says, we're a great resource for you. We have a tremendous database that can give you a lot of great history. A lot of you already know that, but some of you who may be new to these sessions don't know that we have a lot of resources at the department to help you and to give you some past histories. So please avail yourself to us. We're here to help you. So I'm going to put that our telephone number in the chat, and we're a couple of minutes past. So again, I just want to thank everyone, and we will see you next week. Same bat time, same bat channel.
Yep, for earthquakes in chlamydia and gonorrhea management. Bye, everyone.
Bye, everyone.
Thank you.
Bye, thanks.